Welcome everybody to our inaugural webinar. I'm Dr. Andrew Kleek. I'm the Deputy Executive Director at NYU's McSilver Institute for Poverty Policy and Research. And I am here with my CHAMP Network colleagues to present our first webinar, Reducing Risk for Child Maltreatment and Treating Its Consequences, a national training series on the application of causal science. If we can go to the next slide, please. Before we get started, I just want to do a couple housekeeping things. We're going to hit those questions that everybody will ask before we get started. Yes, the slides will be available after the webinar. The webinar is being recorded, and we will distribute, if we can just go back one slide. If the webinar is being recorded, and we will distribute this recording to all the people who are on the webinar today. If you loved it, and you want to, if you love the webinar and you want to share it among your colleagues and friends, please feel free to share it. We want this to get as wide of distribution as possible. Also, this series today is being done as a webinar, which means that folks on the webinar, except for the panelists, are unable to unmute yourself. So the way to communicate with us is through the chat. So if you want to and you have questions along the way, please chat them in. I strongly encourage people to chat in their questions as they come up in their heads. We will probably answer those questions at the end of the webinar, but please chat them in as they come to you, because if you're anything like me, the moment the question comes into my head, if I don't write it down, I'm going to forget it. So chat them in as they come up. Jenna, who is doing all the administration in the background on this today, she and I will record all those questions, keep a list of them, and then when we get to the end, the panelists today will take a shot at answering as many of those questions as we can get to today. We are really, really excited to get started. So we're going to do introductions of all of our panelists today really quickly. So I already introduced myself. Glenn, you want to introduce yourself real quick?
Okay, I'm Glenn Sachs. From the NYU Langone Medical Center and the director of the CHAMP Center. I'm really excited to be here with all of you. We've been planning this for a while. Actually, the ideas for this webinar have been incubating for, 10, 12, 13 years as we've thought about bring predictive and causal knowledge to practice. And so, again, we're really excited to be explaining this to you. I've been working with maltreated kids and families, trauma for a long time, and am really excited to talk about the integration of its science and its practice.
Fantastic. And Glenn, as the others introduced themselves, for some reason it came back off presentation mode. So
yes, let me go back.
All right. Constantine, you want to introduce yourself real quick?
So good morning, everyone. I'm
There we go.
Constantine Aliferis. I'm a professor of informatics, medicine, and data science at the University of Minnesota, where I direct the Institute for Health Informatics. I specialize in causal AI and causal and predictive AI. And my team and I have been working with Glenn Sachs's team at NYU since 12 plus years now, from the time that I was at NYU. This is a long-term collaboration. We aim to bring the benefits of causal machine learning and AI and causal data science to psychiatric research and care. Thank you very much.
Fantastic. Cece?
Hi, everybody. My name is Cece Ma. I'm an assistant professor at the University of Minnesota. My role at the CHAMP Center is to lead the development and validation of the predictive and causal models. And I love talking to people about modeling. So yeah, thank you.
Wonderful. Kate?
Good morning, everyone. I'm Kate Sullivan. I'm an associate professor at the Silver School of Social Work here at NYU. I am a member of the CHAMP Center executive team, and I'm also the project director of the CHAMP Network, which is the translational partner of the CHAMP Center. And we'll talk a little bit more about the relationship between those two projects as we get going today. Great to be with you all.
Oh, Steve?
Yeah, hi, everyone. I'm Steve Johnson. I'm also faculty at the University of Minnesota in the Institute for Health Informatics, and my role on this team is to help us work with all of the data, the EHR and other data that we'll be working with, and help with the clinical decision support to make use of the outputs of the models.
Fantastic. And I introduced myself globally, but and specific to this project, I'm the co-lead of the Dissemination and Outreach Core, responsible for getting all the information for the project out to all of you. And last but not least, Eric.
Hello, I'm Eric Kummerfeld. I'm a research assistant professor in the Institute for Health Informatics at the University of Minnesota. I develop, evaluate, validate, and apply causal modeling methods, especially when unmeasured confounding is a factor. And I co-lead the resource core with Steve. In my case, I mostly provide guidance and expertise when we run into particular issues related to unmeasured variables and in the causal modeling extra stuff that we're doing. Thanks.
Fantastic. All right, next slide. And while we're transitioning slides, I just want to acknowledge Jenna from our team at McSilver and Katina and Michelle from Glenn's team at NYU Langone, who are making sure that all of these things actually happen. So we're really excited to have them here as well. So this work today is really brought to us by two separate centers. The CHAMP Center, which Glenn leads, which is an NICHD capstone center, a National Center of Excellence for Child Maltreatment Research, and the CHAMP Network, which Kate leads, which is a SAMHSA-funded center, part of the NCTSN network. And if we go to the next slide, I will share a little tiny bit more. So the CHAMP Center really, and Glenn's going to talk about this a lot today, is focused on discovering knowledge that will translate into improved approaches for interventions for maltreated children and families with a special emphasis on predictive and causal data science, which is the topic of our presentation today. The CHAMP Network, which is embedded within the national network of the National Child Traumatic Stress Network, is focused on implementing best trauma-informed practices in child welfare prevention and improving results for maltreated children and their families. The next slide, please. All right, and we just want to acknowledge that the capstone centers are that the CHAMP Center is one of 4 NICHD funded capstone centers, one at WashU, one at Penn State, and one in Rochester. I believe some of the folks from some of the other centers are on today, so I want to welcome them. And also, I believe we have some NICHD folks on today as well, so acknowledge both, appreciate their funding and acknowledge their leadership in this work. All right, so with that, I'm going to pass this on to Dr. Sachs, who is going to take us into the presentation.
Great, thanks, Andy. So again, we're really glad you're all here. In our first session of this training series, the focus is going to be looking at the general themes, the goals, the direction of this whole training series. And really, if I'm to encapsulate it, it's to think about practitioners and what we need to help children and families, and how science aligns with that, and how information flows back and forth to drive progress. That's an essential thing for us. And so this seminar is all about that. And just here's some disclosures for you about where funding comes from. And talking now about the overall goals of the training series, what we were thinking about as we put this all together. We wanted to communicate what we believe is a pretty unique perspective on child maltreatment research and practice towards aligning them better to drive progress. And we believe it all is focused on predictive and causal knowledge. And that's the vehicle for which translation needs to occur. Practitioners apply predictive and causal knowledge to improve outcomes in kids and families. And scientists discover and translate it for the knowledge, tools, interventions, so that practitioners can apply it. And then there's administrators, policymakers, who make the knowledge, tools, interventions available for large-scale impact on the population. And all of this is based on producing accountability to kids and families for the achievement of results they're desperate to achieve. And so the webinar, our focus is making it practical for you, which, it's a challenge. When we looked at the roster of people who have registered, it was really great for us seeing so many frontline practitioners, clinical administrators, administrators and policymakers across the service system, scientists of various sorts, and really people are here from around the country. And so trying to make this practical for everyone is hugely challenging, but unbelievably important. And our hope is that this webinar, this training series becomes a vehicle for communication and as we enhance each other's work. And so we aim to introduce methods, tools, ideas for practitioner application and for scientific discovery and translation. So what's today's session about? I wanted to find an essential knowledge gap which can be filled with predictive and causal knowledge, and I wanted to define what we mean about that, describe its application to practice, and then to really elucidate the necessary alignment between science and practice around causal and predictive knowledge so we can help kids and families. And today it's going to be an overview, but it's all going to be unpacked in the rest of the sessions. And one thing you should know is that there are 6 sessions that we've planned now, but we're hoping that based on response, depending on how they go, that this will morph into session 7, 8, 9, 10, 11, that will be refined for what's needed. So let's start with the focus, which we could never forget. This is the question, why are we here? Well, here's our focus. It's all about kids, risk, their future. Nothing matters except for that. This is our true north. And then who is here? Who is in the virtual room, so to speak? I mentioned the roster before, which is amazing, the diversity of people who are here. We have practitioners, we have administrators, policymakers, we have scientists here. And again, this training series is about tying everyone together in the service of helping kids and families. And so it's all about kids, families, and really it's about knowledge in and out, knowledge to help and what we learn from it to keep improving our ability to help kids and families, our true north. Let's spend a few minutes defining the problem. And most of us are pretty aware of this. If you look at exposure to maltreatment, we see that worldwide, so many kids exposed to physical and sexual abuse. In 2010, like 3,500,000 more in the US were recipients of investigation, and then substantiated maltreatment. But we know this is a tip of the iceberg given the small proportion reported. And we also know in the United States about 1,750 kids die yearly from abuse and neglect, which is quite a tragedy. And we have to do better. And then we look at, well, if you are maltreated, what does the future hold for you? So significant mental health problems. We know about the ACEs study, the main public health issues of our time are connected to child maltreatment, social dysfunction, academic dysfunction, and then over the life course, unemployment, homelessness, divorce, chronic health problems, So we have to get a handle on this and reduce risk. So I want to define we're all thinking about outcomes. Let's talk about child maltreatment outcomes, and I'll define it as any deleterious event or events undermining safety, development, health, mental health, adaptive functioning related to exposure to maltreatment or the consequences of exposure. So these are examples: maltreatment exposure, consequences. These are the outcomes when we're in the world with kids and families. These are the outcomes. We have to know about risk and prevention. So then there's the issue of the state of our knowledge, and we think of all the studies of every sort that is supposed to inform this. So we look at the etiological literature about outcomes, and so many studies of so many different types of factors, but if you think of it, few are really assessed and used in routine care, even though their treatment implications are routinely discussed in research articles. And interventions available for exposure's consequences are only loosely and informally based on the etiological literature. Few novel interventions have been released over decades, and the effects of the interventions released, studied, and randomized studies are usually far weaker than when delivered to the population observed in the trial, and not effective for many of them. And so, as I've said before, there's a central problem related to the alignment between knowledge generation and knowledge needs. That's represented right here. And we believe in the middle of everything is predictive and causal knowledge that flows inward and outward of this picture to keep, so that we could keep refining our knowledge to drive progress. So I've used the term predictive and causal knowledge a number of times now. It's central for this training series because we believe it's central for the field. So I want to just clearly define terms now. So key definitions. Let's start as simply as we can. Think of two factors, two variables, A and B. A is any risk or protective factor you could think of for any of the outcomes, and B is a maltreatment outcome that I've defined before. So let's just think simply of these two factors. So predictive knowledge, factor A predicts factor B if knowledge of the value of factor A informs knowledge of the value of factor B. And so, this is statistical associations, correlations between group differences and observational studies. And again, in our field, for humans, we can't do experiments. So almost all our knowledge, human knowledge, is observational about factors and etiology. And so the way this works clinically or in practice, it's using assessment information to classify a kid for their risk for a maltreatment outcome. What does the clinical data tell us about future risk? What about causal knowledge? So factor A is causal of factor B if the value of factor B is dependent on the value of factor A. So this is all about intervention. If B is dependent on A, then changing A's value will result in a change in B's value. But if B is not dependent on A, changing A's value will have no change. So that if we do intervention, it's not going to make any difference. So here is a central question. how can A predict B without being causal of B? And this we submit as a real problem in the field, is confusing predictive and causal knowledge. And it's all about knowing things about what interventions might work. So brought into the field, it's the use of assessment information to classify an individual for their probable response to an intervention that can lessen their risk. So when we move into the world of causation, again, it's all about intervention. And if we only use predictive knowledge for this, we're going to be really mistaken. So let's talk about why predictive knowledge isn't also causal necessarily. So here's something: lung cancer and yellow fingers are highly, highly correlated. This is a replicated finding. It's as robust as you could possibly imagine, but it's also pretty meaningless because both are caused by smoking, and we care about smoking causing lung cancer, not yellow fingers. We might want to scrub yellow fingers as much as we want, but it's not going to change risk for lung cancer, and that's because of confounding. So this relationship is spurious. It's not meaningful. However, if we do studies, it's always going to show a very significant relationship. This has deep, 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 deep implications for our field. And the common cause principle of 1956, any factor that's an effect of a cause of another variable will be observed to correlate with that variable confounded by their common cause. So it looks like this. There's the cause, the effect. And so how big a problem is this for maltreatment outcomes? Well, think about any maltreatment outcome you're interested in. How many factors do you believe cause it from any domain? Biological, social, developmental, whatever it is. Most of us believe that it's multi-causal, usually a lot of causes. So that's a problem, because any of those causes, any that's not measured or looked at in the study, is a source of confounding for results. So we may send, we're not doing, these are observational studies. So it's very easy for us to believe a result that is strongly related might have treatment implications, but is actually confounded by one of the many causes that of the outcome. So I'll show you, a good example of that, and not to pick on this study, but it's kind of typical, where this is the Stith and all meta-analysis of maltreatment exposure and risk factors for this. This is for physical abuse this is many, many, many studies they looked at for physical abuse, and using pretty rigorous methods, found the studies that were most commonly found with effects. These are all with p less than 0.001. There's 29 factors here related to the exposure of physical abuse. And so when you look at this, which of these could be promising intervention targets? Will you decide to focus on any of them? Certainly the meta-analysis, again, which is, I don't want to pick on it, it's a great study, but it makes the point about you're not really able to know any of them, whether it's an intervention target, unless you can look at the cause. And later we'll be talking about methods, which we use a lot. It's central for the CHAMP Center of causal methods. with observational data, which is very important because, again, all our studies, human studies, are observational. So let's just choose 5 of these factors. Parental history of child abuse, parental depression, parental alcohol abuse, family conflict, child externalizing behavior, all of these found to be related to risk for exposure to physical abuse. So here's something to think about. How might they be related to each other? And we'll be looking at figures like this a lot during this training series. So suppose they're related to each other in the following way. Parental history of child abuse leads to causes parental depression. Depression causes alcohol abuse, which causes family conflict. Child externalizing behavior also contributes to family conflict. If this is true, and remember that common cause principle, then you get this confounded. You see that, and then this disappears. So these are not, you could intervene on those on parental depression all you want, or parental alcohol abuse. It's not going to change exposure to physical abuse. So again, this isn't I didn't put this figure together from a study, but it just shows you that if this is the way causal relationships work, then you're going to get confounding like this. Similarly, and this is called causal structure, the structure of how causal or factors fit together. So you might look at this. However, what if this wasn't part of the study? SES would confound this. What about a gene causing both parental alcohol abuse and child's externalizing behavior? Or what about parental job loss leading to that? Then we have this source of confounding, and these relationships are spurious. So again, I'm putting this out there to show you how careful we must be. Okay. So a few years ago, some of us put this together in a paper focused on mental health progress, and it's very applicable to everything we're talking about. And we proposed the causal exclusivity thesis. And I'll read it. Outcomes can be systematically improved through intervention on their causes and in no other way. Therefore, a health field without the tools to distinguish causes from non-causal correlates and without a diagnostic nosology to encode this distinction cannot advance. Again, this summarizes really what I've been talking about before. We'll be talking about diagnostic systems later in this series, but that fits together here as well. Okay, let's bring these ideas to the world of children and families as we try and help them. Let's start by considering the needs of just one kid. Who is she? She's a kid who might be at risk for exposure to maltreatment, or she might be at risk for exposure to one of its consequences. What does her chance of a better future depend on? You and me, practitioners, need to help her. What does a practitioner, what must a practitioner do so that this child might have a chance at a better future? So she has to be able to see the future to tell the risks the child faces. And if she believes the child is at risk in the future, she has to intervene in a way that might lessen the risks. It's all about seeing the future, all about prognosis. We need our crystal ball to see the future, and we need help with that. We need our scientists to help. We need our administrators, policymakers to help us have the tools and knowledge of our science accessible. That's what seeing the future is all about. So let's drill down a little more about seeing the future. And I'll categorize this as first principles of care. Start here through crystal ball. So it's all about two questions and only two questions. Is she at risk for a bad maltreatment outcome? And if she is at such risk, what can I do to reduce her risk? That's in the middle of everything. And I'm talking, I use the term clinician, but this could be any professional in the child service system related to maltreated kids about what we can do to help. Child welfare caseworkers, all of that. It's what can we do to help? It's all about seeing risk and seeing how we would reduce future risk by intervening. So what might be we be worried about for this kid? What outcomes? And it's really about classifying, like yes or no, risk, no risk. Is she at risk given the information we have, the clinical data or any data we collect? And if she is at risk in the risk category, what could we do to transform her not to be at risk, to reduce her risk? Two things. That's the focus, two things. And one is based on predictive knowledge. The other is based on causal knowledge. And so the requirements for us to be successful, we have to define our prognostic maltreated outcomes. What's the time frame? And can we classify kids into populations relevant for 1 and 2? If there's a classification, are they at risk? Yes or no? And then if at risk, that's a subclassification based on causal knowledge. Are they responsive to a given intervention? And we need our scientific literature to do this. So all the questions we might ask for helping a kid and family require predictive and causal answers. Again, drilling down even more, let's think of this kid. This is a 15-year-old girl who lives with the substance abusing stepfather. We're going to gather lots of other information, but what about the information we have? How might we use it? So these are the two questions. Is she at risk for sexual abuse because she lives with the substance abusing stepfather? And if she is at risk, can I reduce it by referring stepfather to substance abuse treatment? Obviously, this isn't the only bit of information that we would gather, but all information requires that we understand the risk that it puts someone into so that we could see whether we need to intervene or not, if they're at high enough risk, all of that. I know everyone understands that. So this practitioner is a modern practitioner, and she tried to approach this by sending this question to ChatGPT. Okay, we all do this, right? So we could see it, and this is an actual answer with references that she got when she did such a search. And if you look at this, indeed, stepfathers and with substance abuse increase the risk. Here's those references. But I also want to point you to the last sentence. these findings emphasize the necessity for targeting interventions, preventive measures in families affected by substance abuse to safeguard vulnerable youth. So AI or ChatGPT doesn't really understand the distinction between prediction and causation because this sentence confuses the two. So predictive knowledge, causal knowledge, you get the point here. And how might we be confused here? So here's different models that might happen. Now, when I put a model like this, assume this describes nature. So here's one where you have a stepfather's impulsivity leads to their substance abuse, then leads to sexual abuse. And so in this example, if you intervene on substance abuse, you will reduce the risk of sexual abuse. But you might find it looks like this, where impulsivity leads to substance abuse, but is a common cause of substance abuse and sexual abuse. Their relationship is confounded. So in the literature, you would see the correlation, just like, yellow fingers and lung cancer, but you could intervene all you want on substance abuse and it's not going to change sexual abuse. And then you might find there's lots of different factors are involved. It could look like this, where both stepfather's impulsivity and stepfather's substance abuse separately lead to mother's depression, and maybe that means she's less protective, more withdrawn, lots of reasons for that leading to there. And so if you only focus on substance abuse, you may not sufficiently reduce depression. There's still the impulsivity that you need to worry about, and it may not really give you the effect you expect to observe. And so that's how this works when we bring it right into the clinic or the session with children and families. I'll give you another example here. So this 16-year-old boy with the diagnosis of PTSD from physical abuse has impulses to take an overdose of medication. Okay, here you are again. What does your crystal ball say? You need answers to these questions. Is he at risk for self-destructive behavior because he has PTSD from physical abuse? And if he is at risk, can I reduce it by treating PTSD? So again, you do your AI search. Are teen boys with PTSD from physical abuse at increased risk for self-destructive behavior? You get a definitive answer here. The computer tells you the evidence suggests that teen boys with PTSD resulting from physical abuse are indeed at greater risk for self-destructive behaviors. Again, here is the confusion. Mental health professionals must recognize these signs, provide appropriate interventions. Again, not distinguishing prediction causation, but giving good references that also don't make that distinction. Again, here we have differences, but focusing on causation. And again, in subsequent sessions, we're going to really dive into how with science we can infer causes even from observational data and get models like the ones I'm showing you, and I'll be showing them a lot. So again, when I show this, assume these are different versions of nature that we have to discover. So it could be physical abuse leads to PTSD, leads to self-destructive behavior. Then intervening on PTSD will reduce self-destructive behavior in this kid. But it might be, PTSD doesn't just arrive, it comes out of the brain and body. And so I want to just put that there. There's a certain brain state, however we might define it, the amygdala activity, however it is, there's an extensive literature. So we could intervene on brain directly or PTSD symptoms, but that then leads to different potential models that we don't know, that the literature doesn't really distinguish if it's not able to infer causation from observational data. So here, PTSD, if you treated it, would have no effect on self-destructive behavior because both come from this brain state. Or here's something that also can happen is that, well, we know depression is related to PTSD. Well, how does it work causally? There's actually a number of causal studies, including one we did, where depression itself follows that. And so you might have this also. PTSD is, humans made this construct that it fits together, but causally the different components of PTSD, how do they hang together? And so in this example, arousal and avoidance comes from intrusions and numbing comes from intrusions. There's a pathway from intrusions, numbing, depression, self-destructive behavior. But if we organize treatment of PTSD, it's any focus on arousal and avoidance. If you could see, there's no line from that or arrow to self-destructive behavior, it will not have any effect, although depression, numbing, intrusions will. And so it's just important for us to think about that. Anything in a line with arrows is causal and can have an effect. But one of the things we'll be talking about is there's varying magnitudes of effect that we must estimate and know. Some will have large effects, some will have small effects. Usually, if it's proximal to the target outcome, it will have larger effects. That's not necessary, but we're looking for that because we need to estimate the magnitude. But you could see in this business, in each of these figures, if they were true, all the variables will correlate with self-destructive behavior, but the ones that are not connected are confounded by those common causes. And so, again, we have to be very careful about this if we want to know how to intervene. Okay. So, again, in the examples, we're only giving you like a couple of factors. The real world is more complex. You ask you're assessing many different things, and you need to put it together to understand risk and the means to reduce it. So how many factors? Well, in this example, only 2, PTSD and physical abuse, were given. But what are guidelines here? So if we think about prediction, any factor correlating with the outcome is predicting it. Now, the challenge for the field really is finding a set of predictive items that can, one, be practically measured in care. So if we have a model here, or we have knowledge of like 300 factors or whatever, and it takes like 8 hours to assess it, it may not be practical. So we're looking for a small number of highly predictive factors, which can yield clinically significant predictive accuracy. How might I define that? Really here, it's what will reliably, accurately put kids knowing risk or no risk. What is the set of those factors that could be practically assessed in care? And then causation, any factor with an unconfounded effect on the outcome is a cause. Our challenge for the field is knowing causal factors that can be practically assessed in care. For example, if we have a causal factor that needs, very expensive, fancy brain imaging. It may not be practical in care, or there may be other like molecular, we have to be thinking about what can be assessed in care so it can guide knowledge. And then factors that are causal will vary in terms of their magnitude of effect. So it needs to be of a clinically significant magnitude. And how might that be defined? Well, be defined as the magnitude enough that will put someone from risk into less risk or no risk. And then, of course, there needs to be available interventions that can effectively target the cause. You target a causal factor with a large effect, then you expect that the outcome would be reduced. And I just want to, let's bring this model back. And again, we're in a multi-causal world, so let's make this more realistic and more complex. So perhaps we have a gene that also causes this brain state, let's call it X, and maybe the brain state causes another brain state, Y. It could be, obviously in the real world, genes cause brains to act in certain ways, and different parts of the brain connect with each other and influence each other. So this is going to be, there's going to be many, 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 many connections that are going to be part of our work. And let's say, intrusions also cause high cortisol, maybe leading to arousal and high resting heart rate. Maybe there's additional causes here, maybe family conflict. Also, maybe recent loss causes self-destructive behavior. And maybe these have effects like family conflict causing parental separation, recent loss, recent school absence. So you should know that these are 15 factors here. All of them will be statistically associated with self-destructive behavior in articles that you'll read. If this model is true, again, I made this up, but if this describes nature, if this is the process that generates the data, then all 15 will be, you'll find statistical association, which will be replicated, all of that. But the problem here, if anything here, it does not have an arrow leading to self-destructive behavior, again, it's confounded. Now, this leads to what could be assessed. So, here are the 15 factors. Cumulatively, well, all of them predict self-destructive behavior. All of them predict it. But only the ones that are bolded and bigger are on that line to self-destructive behavior. And then what I've done in red, I've just said, again, this is made up, but when we model, we're measuring this in research and all of that, which we'll be talking about in later sessions. But maybe family conflict, depression, and recent loss are causes with large effect. Then they become your treatment targets. That's going to be the way to reduce self-destructive behavior. Okay. So I want to say a few things about aligning maltreatment science and practice. So here is our trusty friend, their crystal ball. And then we want our scientific literature to be how we read our future. So let's go to our science, and here is just how it fits together. So let's say we do a study, there's 1,000 children. In this study, the subjects are assessed for hypothesized risk protective factors. we have our research data. Then we take our data, we use predictive methods. What do? They classify machine learning predictive methods, but any rigorous methods classify risk or no risk. And then again, these are made up numbers, but then you could see that how the variables you have in your model with rigorous predictive methods will tell you who will be in the risk group and in the not risk group. And then causal methods take the risk group, subclassify them. Here it's assuming it's discrete. If you're vulnerable from cause A, not B or C. But here you could divide that group and, let's say this is the proportions of those at risk. So this is important. And in your assessment, the way they're vulnerable to the cause is the assessment information says they carry that variable, they endorse that variable, and it's a causal variable that has large effect from your causal method. So this tells you a lot about intervention A, and I'm defining this as intervention A can change cause A, but doesn't change cause B or C. So then you can shift these kids from risk to less risk. But if the other kids for cause B or C, this isn't going to work. And that's deeply important. Now, let's take this knowledge and bring it into the field, into practice. So we have our child and we're assessing her for what we know from the literature, the hypothesis, risks, and protective factors. We have our clinical data. We have our knowledge about what the variables mean for prediction, knowing whether she is at risk or not at risk. And then we take what we know from the literature about that, is she going to be responsive to interventions based on what we know about the causal factors? Again, here is how it works. So you see the parallel here between this and how causal and predictive knowledge needs to align and make each other better and better and better, because if a finding of a cause, we think an intervention would work, but what if it doesn't? So now we have to go back to the drawing board. What did we miss? But if we're not aligned in that way, then we have no chance of using evidence from practice to, refine our scientific knowledge and vice versa. It's actually, I've mainly talked about two things. Like we have to, one, define a kid's risk, and then if they're at risk, see the intervention that might work. But it's really about one thing, actually. Effective care requires the capacity to make accurate predictions of maltreatment outcomes under intervention conditions and learn from the predictive results. So basically, prediction of outcomes under the no intervention condition is the first one. So I assess a child. If I'm thinking, if she doesn't get intervention, what will her risk be? And then if I were to intervene in this way, what do I know about how that would be reduced if I intervene in that way? So it's all about, and if you're a clinician, you do this whether intuitively. How many of you have applied and recommended an intervention if you weren't predicting that it would work? So we do this all the time. Or when we choose to intervene, it's because we've decided that they're at risk for some outcome we're worried about. So this is in our minds all the time. But what we're talking about here is how to make it a little more formal, specific, effective, and again, aligning science with that. And here is one way of thinking about how it works. And for me and us, your faculty, it's all about getting better and better and better. That's what progress is all about. It's a complex world. It's hard to get it right. So we need always the process of learning. And this cycle is the learning cycle with predictive and causal knowledge. So we gather the data, clinical data, practice data. We then predict the outcomes under intervention conditions. If we believe the person's at risk, then and an intervention we believe will lessen it, we intervene. We measure we check the outcome results. Did it work as we predicted it would, as we expected it would? And we compare the results. If it worked and kid got better, risk was reduced, all of that, then we're really good. It gives us confidence. But if it doesn't, we have to refine our understanding and our intervention approach, change it, gather some data, and keep the cycle going where we're always predicting, intervening, measuring, comparing, refining, all of that. And of course, to do this well requires our scientists to be aligned with this process. So needing to think about discovering robust causal and predictive findings that would hopefully be tested in the real world, building assessment and classification tools on that knowledge, testing interventions, developing interventions to target causes, and developing and refining and testing tools to support the implementation. And that's how things can be aligned. So that's the content for today. I just want to look forward to where we're going. So we just finished session 1. The next session, which is February 11th, it's I'm gonna fill in gaps here, especially talking about personalized, precise work. How, if kids and families are complex, we have to really get that right. And that's where causal predictive knowledge comes in. So I'm going to be really building this idea. Then it's session 3 is going to be get even more practical, where we'll be looking at a lot of examples of predictive and causal knowledge in practice, even sharing some tools. Because again, this needs to be practical for practitioners. And part of it is, even if the scientific knowledge may be limited, even if the literature you're feeling isn't right now informing your practice like you would want, how do you predict, how do you do what I was talking about before? How do you predict the results of intervention, intervene, measure the outcomes, refine your knowledge based on that? That's what this session's about. Then we'll focus more on the scientific paradigm and look at its limitations, and for producing the predictive and causal knowledge needed by practitioners. In session 5, we'll be talking about ways of advancing the science and giving you examples of what we're doing in the CHAMP Center and what other people are doing, especially with causal data science methods that are able to infer causes without experiments. And then one of the goals here is to take robust predictive and causal knowledge from models and build it into tools to help practitioners to realize the potential of the scientific findings. And so we'll be talking about that. And again, we've planned 6 sessions, but depending on how this goes, your response to this, the discussion, session 7, 8, 9, until you're sick of us, we want to continue this and then refine the ideas for the next sessions based on how this goes. And that's all I have to say. Thank you.
So thank you, Glenn. We're going to jump in and get questions from our audience today. I threw it in the chat just a minute ago, but please throw questions in the chat. There is no question too simple, or there may be questions too complex, but there are definitely not going to be any questions too simple. So I encourage folks to throw questions in the chat. As we get started with that, I just want to highlight that Jenna, the McSilver admin account, put in the link to register for future webinars. So if you haven't registered for future webinars and you're interested, by all means, click on that link. And she just threw the survey into the chat just now. I would strongly ask folks to fill out that survey. This is new for us. This is our first one of these. This is an incredibly complicated topic. And so we are really going to be relying on your feedback as we go into the next session of this series. So please fill out the survey. It's really quick. It'll only take you a minute to fill it out. So while you're listening to the Q&A, you can also multitask, as I'm sure many folks have been doing through the webinar, and fill out the survey. So I would just like to start us off by asking just a question for Glenn and Kate as well. We mentioned that this work is being built on the work that's being done at both the CHAMP Center and the CHAMP Network. And Glenn, I'd just like to start with you and just ask a question about how do we go from the science part of this to the actual reality on the ground, and how does this get from what, at least to me, is very complicated to clinicians sitting in front of that kid in the office and what they're supposed to do? And how will the CHAMP Center help with that?
Yeah, no, thanks, Andy. And as you're saying, it is really complex. I don't want to be presenting this as an easy answer, easy solution. If it was easy, it would have been solved a long time ago. It's also people have done, even though we're identifying gaps in the field, there's also great work in the field. So I don't want that message to come across. But getting it right requires that we really think differently, and everyone's expertise is needed. You know, as we're saying, it's practitioners, it's administrators, it's policymakers, it's scientists, it's children and families and their experience and all of that, because it's complex. And unless we're aligned to gather and use this information, we're not going to move the needle forward. And so this is really important. Now, I was hoping you or someone would ask this question, because I do have one final slide to talk about here. And I'll just put this whole thing together. And so the idea, and this is really how the CHAMP Center is organized. So you notice our friend here has something circled in red in her hand. Let's call that a decision support tool, which is really advanced to be able to make decisions based on causal and predictive knowledge programmed into it based on the clinical data that's gathered. So how do you, if you look at the slide at the right end, is you have the tool in your hand, but how do you get there? And really it's going to be about a process where, and within the CHAMP Center, we take huge data sets with outcomes, the maltreatment outcomes we're interested in, and thousands and thousands of potential factors that might be predictive or causal, and we build robust predictive and causal models that might have potential to go into the world, but it's not going to be based just on models that we build in computers. Then we want to get the expertise in the world, experts in clinical care, implementation science, administration, children, family, all stakeholders to look at this and, can things be measured in the world? Are there available interventions in the world? Are they practical? Is this ethical? Are there risks that we need to think about? All of that. So there's like an intense process of communication where diverse expertise, knowledge from everywhere needs to come together to look at that, and then choosing models that we believe for specific maltreatment related outcomes that can actually fly, and then building those tools so they can be used in the real world, and pilot testing them, and all of them doing trials on them, so that again, when we get to the right side here, we have these tools that we could put in people's hands. And again, there's only two questions. Is she at risk? And if so, what can I do to reduce that risk?
And Kate, I know you wanted to just touch a little bit on the CHAMP network and what it's going to do, and then we've got a couple questions I want to make sure.
And should I stop sharing the slides?
Yeah, and then people could see us.
Okay.
Yeah, thanks, Andy. So, I think one of the things that's really exciting about this endeavor, and Glenn, you at the beginning of this presentation, you were talking about knowledge in towards practitioners and towards the children that we serve, and then also knowledge back out. And I think the opportunity to have both the CHAMP Center, which is focused on knowledge generation, and the CHAMP Network, which is really focused on delivering services to children and families that is informed by this kind of the scientific knowledge that we're generating, is really exciting. And I think it's also, as you were just saying a second ago, Glenn, really exciting to have the opportunity to learn from practitioners on the ground, to feed information back out to the scientific community that might also be helpful in helping us to understand and apply the causal knowledge that we're generating. The CHAMP network is really focused on supporting the child welfare workforce in particular in developing their skills in and in implementing evidence-based interventions. And I think one of the tensions in the CHAMP Center, CHAMP Network flow is, I'm a social scientist by training, but I'm also a clinical social worker. So in addition to sort of developing and testing evidence-based interventions, I've also spent my career implementing them. And certainly in the child maltreatment world, there's a premium that's been placed on evidence-based interventions, which are time-consuming to learn, time-consuming to implement. So at most social service agencies, we can only really offer a relatively small number of those evidence-based interventions. And that's the case in the CHAMP network, that we're focused on one particular intervention, trauma systems therapy. So one of the tensions here, I think, is sort of the degree to which the evidence-based interventions that practitioners are trained and ready to implement match up with the causal factors that they potentially can identify in the children and families that they're assessing and working with. So, how practitioners in the field match up this understanding to the expectation that they'll only be able to apply a small set of evidence-based interventions. So I think that's something that we can explore as this conversation goes on. And I'm also really interested in thinking about that kind of knowledge back out pathway, how we can learn from the practitioners that we have in the room today, to be thinking about how the scientific community can better support the delivery of the kind of practice that we're talking about here.
Fantastic. So we've had a couple questions come in, so I just want to get to one. And one is a little long. I'm not going to read it word for word, but I try to get to the point of it. One of our attendees is asking, they've participated in a wraparound program that addressed a number of what I think, Glenn, you would refer to, some as causal factors and some as predictive factors, right? addressing substance use because it reduced impulse control, addressing depression because it pointed out it reduced the mom's ability to protect, etc., right? Addressing a variety of these different factors. The question, I think, is around, are we supposed to ignore all of these other things if they're not causal? Or how do we think about these other factors that are important, but not necessarily causal in terms of preventing future abuse?
Yeah, it's a really great and important question because there's all these interventions out there. Many of them have been studied in, clinical trials, that sort of thing. One of the things, and I think about this a lot, that often when an intervention is developed, its developer loosely knows the literature and uses the literature to guide the development of the intervention, uses their clinical experience, that sort of thing. And often the literature that guides them, sometimes you can confuse predictive and causal factors, that sort of thing. So we have interventions that work not for everyone. And often the results are weaker than they were observed in the trial. And the reason for that is that they weren't defined with precision for targeting causes at all. And so we have them, we use them, they work for some people. It's hard to know if we don't know the causes, who it will work for. And it's, think about it this way. If we think people are complex because there's a great many causes, then how could it work even in theory if everyone, say, with substance abuse gets the same thing, or everyone with depression gets the same thing? If the only reason they have depression is because there are many causes for depression, then again, even in theory, these broad treatments that are delivered for everyone, it's not going to work, and it's going to expose people to some risks, iatrogenic risks that they, don't need to be exposed to because they don't necessarily have those factors. So the question identifies a real problem with the field. I mean, we have these interventions and they're effective sometimes, so we need to keep using them. But I think in this seminar, we're looking for a way of moving the field forward to make it better.
Yeah. And it sounds to me like also, if you're, I don't want to use parental depression, and I'm not saying parental depression is causal or not causal of child maltreatment, but if you're treating parental depression, there's value in that. But you should be thoughtful about, if you don't know the causal factors, you should be thoughtful about what you're using to, what your intervention is going to lead to. It may lead to a reduction in parental depression. It may or may not lead to a reduction in risk for child maltreatment. And that's where the causal science piece comes in.
Yeah, exactly.
So one question about what types of services the CHAMP network is providing. Kate, we're doing trauma systems therapy, right? That was an easy one.
Yeah, trauma systems therapy, and also a number of other vehicles to provide training in trauma-informed care to child welfare prevention caseworkers, and also to masters in social work students who will hopefully enter the field to deliver trauma-informed services in kind of the year after they participate in the network.
Fantastic. How do you help parents that are struggling with really acknowledging the issue of their own children's mental health risks and those challenges associated with that?
Yeah. So this is, it's a tough clinical question, right? Often what happens in the world, and we see this, when I'm not doing science, I'm in the clinical world disseminating trauma systems therapy, that sort of thing. And we see this all the time when there's not an acknowledgement, and especially when we see clearly a contribution of the parents to the child problems. And, I have a bedrock value that you can't treat a kid without their parents, without their family, all of that. Trauma systems therapy is based on that. So part of it is to be empathic, obviously, but also clear. If you see that there are things the parents are doing that repeatedly lead to problems, you ignore that at everyone's peril, and you just need to be really clear and understand, you know, understand the parent, what's most important to them, understand why they're doing what they're doing. Maybe they have their own history of abuse and trauma. Maybe it's all they think they could do. And so we have to be clear, but we have to be deeply empathic, or nothing's going to work either. And we'll be talking more later about more of the clinical approaches. I'll be talking more about trauma systems therapy in the third session, because it's actually based on a causal model of traumatic stress in children, and using it as an example of how this works.
Wonderful. So there's a question about how or does this model or do these models change if a child has already experienced maltreatment and versus a child who has not experienced maltreatment, and does that change the risk factors?
Yeah, I mean, part of it is, again, when we look at outcomes, we want to look at who's at risk for maltreatment exposure. And then if you are exposed, what sort of risks, of what are the consequences there? And so we're looking at exposure as one of the risk factors always. You're on mute, Andy.
Yeah, I picked up on that. What do you see as the key sources of data, including panel study data, new data collection, administrative data, child welfare data sets, et cetera, to support these activities? So what are the key data sets that really we should all be thinking about as we develop these models?
I see it's Chris Connell. Thanks for that question. That's a great question that I would expect from you for sure. You know, an ideal set has a great diversity of variables, looking at, you know, certainly well-characterized outcomes, as we've talked before, but also diversity of variables. The administrative data in the world of maltreatment is key. It's hard, and I know you're certainly working on this, about integrating administrative data, clinical data. Ideally, especially if we're looking at maltreatment consequences, different disorders, self-destructive behavior, all of that, it's looking at other causes for that. I mean, the ideal data set would include biological information, brain imaging information, molecular information. Now, we look hard for data sets that have broad diversity of variables, lots of subjects, obviously, but that's generally what we're looking for. It's hard, nothing's ideal, but the broader the better from my point of view.
All right, so I'm just going to make a pitch, two pitches real quickly. If anybody has additional questions, please throw them into the chat. We probably have enough time for one or two more. And also to remind you that in the chat is, one, the ability to sign up for the next webinar and all the other webinars in the series, and two, to please fill out the survey, and you can do it now before we even hang up. And Jenna just threw both items back in the chat.
I want to just expand on my answer too about the data. Well, one of the reasons we need to look at many different categories of variables as possible is anything we miss, if it actually is causal, becomes the source of confounding. It becomes the hidden confounders, latent confounders. Eric Hummerfield introduced himself earlier as, you know, that's one of his focus. He's one of the few people looking at latent confounding, which is a real big thing.
And what is a latent confounding variable? Just real quickly.
It's something that's not measured. I mean, there's only so many variables that are in a data set or you do in a study. So you don't measure it, but just because you're not measuring it doesn't mean it doesn't have an effect on the outcome, and it doesn't cause a factor that you've measured that you might presume is a cause of it, but it might be like yellow fingers for lung cancer. You know, you don't know that if you're not looking at the latent confounding. Eric, do you want to add anything to that?
No, I think you summarized it pretty well. The latent confounders are just a complex sort of mathematical and statistical problem that you face with any real world data set, because for lots of reasons, you're never going to measure absolutely everything that could be of any importance. And so when you don't know what other things are going on, you have to take that into account and consider that oftentimes there's factors that we haven't thought of to measure, or maybe we've thought of measuring them, but we just didn't have the money to measure them in that study or whatever. There's a lot of different things that can lead to this happening. So it's just one of those things that it's important to consider and try and protect yourself from during the modeling.
Fantastic. Thank you. All right. There was also not a question, but a comment that we may also want to look at the OCFS FASP safety and risk factors utilized by practitioners in child welfare as possible predictive factors. So we'll put that on our list of things to consider. I am not seeing any other questions in the chat. So if there's anything else that people want, now is your last chance to throw in the chat. While we're giving people that opportunity, we really want to thank everyone for taking an hour and a half out of your day to join us today to participate in this. People have stayed on, so we're really excited about that. One last pitch to fill out the feedback survey, because that's going to be really important in the in how the next one lays out. And Glenn, if there's anything else you or Kate want to say before we wrap up, by all means jump in, and then we'll let people go back about their day.
The only thing I'd say is I really appreciate everyone's participation. And again, the diversity of people here from, you know, practice, science, administration, it's really an opportunity. I'm hoping even building a community out of this training series, that we could really get people's feedback, get people's knowledge. We could build in sessions involving discussions and breakouts and all of that as we move forward. So I'm really excited with all the participation here.
Well, thank you to everybody for joining today. Thank you for Glenn and Kate and our whole team for being part of this today. Please sign up for the next one. We hope to see everybody again in February. If there are people that are not on this webinar that you think would be interested or benefit from this webinar, please forward those invitations on to them as well. We started with an invitation list of people, of friends and family we knew, so to speak, and all the different networks we have, but I'm sure there's a lot of other people around the country who would be interested in this topic. So please feel free to pass that along to them. And with that, I think we're going to wrap up today. And thanks again for joining.